So John and the faculty, actually the stars of the show, of course, I think the patients and their carers here. So it's one of the few opportunities I get to talk directly to the patients. It's obviously last year, I hope some of you came, and COVID has stopped us from working together. So I have as much to learn from you as you from me maybe, and I hope I race through this. As I said, the problem about asking me to speak last is that I did actually, if I'd started at the beginning, I probably would have added more slides, because you stimulate some ideas like, oh, maybe I should talk to them about that. Oh, maybe I should talk about that. So it was 30 slides, it's now 36. But that's pretty good for me. So here we go. So I'm Kai Keane. I'm a GI medical oncologist at University College London Hospital. I'm an associate professor at the Cancer Institute, and my clinical research, including trials and basic research, is now very much around immunotherapy for patients, and particularly GI cancers. And obviously this lends very well to Lynch syndrome. But I have been asked to talk about treating MMR-deficient cancers this time, so not just colorectal cancer, which is a tall ask because I don't treat all MMR cancers, as you'll see. Here are my disclosures, which I think are relevant to a degree. And you've all seen this before. I'm not going to explain the biology of Lynch syndrome, but I think more important from a therapeutic point of view, okay, if you have been reading the newspapers, everyone wants to be on immunotherapy. There are two main classes of approved drugs, okay, called checkpoint inhibitors. Everyone's talking about pembrolizumab, nivolumab, ipilimumab, and some other drugs are coming behind because in the past, ipilimumab was felt to be very toxic for patients with bowel cancer because of the risk of colitis and hepatitis, okay? And of course, the key problems, particularly in advanced disease, patients have already got short bowel, okay? They've got stomas, they're in bowel obstruction, they've got a very bad liver disease. So the feeling was that ipilimumab was too toxic. And it's very important from a therapeutic point of view to understand that when we first actually looked at checkpoint inhibitors, ipilimumab was the first drug, and it was used in melanoma, and it was amazingly approved by the NHS on a survival benefit, okay? Nothing about response rates, nothing about progression-free survival. That means it didn't really shrink the cancer at the beginning, it didn't seem to make the patients live longer before they relapsed, but there was this kind of tail on the curve, okay? So rather than 8% of patients living at 5 years with melanoma, it was like 15%. So how did NICE approve that? I mean, it's an incredibly expensive drug. But the concept was this: when you upregulate your CTLA-4 pathway, you're slowly upregulating all your T cell regulatory cells, which takes time. It's very powerful, but it takes time. Whereas these killer T cells, which are regulated by this thing called programmed F1, act very quickly, and they act in the tumor microenvironment. So think about ipilimumab being like in the whole body, upregulating your kind of general immune system, but it takes a while, whereas the things that are going to act quickly are acting in the tumor itself. So that's why most of the drugs, not just in Lynch syndrome, but everything else, are around these PD-1 inhibitors, okay? So we'll talk about that later because it's relevant for patients with Lynch syndrome about understanding the toxicity profile, because more doesn't necessarily mean better. And I think this is the important thing. So MSI high, okay, is seen across many tumor types, okay? So it's kind of depressing where it says pancreatic cancer 0%, okay? But I will show you later that, of course, it's never 0%, all right? But the vast majority of patients, of course, we already know, especially endometrial cancer, which I don't treat, okay? But they've known it for ages. They've known it for ages. Whereas I almost think kind of colorectal cancer is kind of coming behind the gynecologist. But somehow we've managed to get the drugs in quicker, and I'll show you why in a second. But I'm just saying is that MSI high is seen in many tumor types. And certainly in my practice, I would actually, it's a cheap and cheerful test. We've already talked about MMR testing. It's an IHC test. There's no harm in just testing everybody, because even if it's a very small chance that you may be MMR deficient, the benefit of immunotherapy is absolutely colossal. Okay, it's transformative. Sorry, did you want to take a picture in? I'll give you the slides later.
That's all right. It's just a reminder.
And I think it's just a reminder of, again, it's not the biology. Hopefully you understand that the general feeling of how immunotherapy was working in melanoma and lung cancer was that in melanoma, it was sun-damaged skin, lots of tumor mutations from sun, UV light. In lung cancer, because you were smoking, lots of mutagens, and therefore you didn't need too much to stimulate your immune system, to upregulate your T cells, to kill these highly mutated cells, okay, with all what we call foreign or neoantigens or clonal neoantigens on the cell surface. So if you think your natural system in this syndrome is you've got a hypermutated state, yes, you've got a mutation of your DNA repair genes, so you're already naturally hypermutated. That's why, unfortunately, you get cancers early and in many places. But actually, that is a reverse bad prognostic marker now to be incredibly powerfully good when you give immunotherapy. So if you see here, I don't know, we have the, sorry. So if you look to the right, this cartoon basically shows the objective response. That means on a scan, things are responding, how many patients respond, gets higher as the tumor mutation goes higher. And you can see on the far right, MMR-deficient bowel cancers, but also you can see non-colorectal MMR deficiency, and this is what I'm talking about. Non-colorectal MMR deficiency also seems to be incredibly good. These are small numbers, but this is the key thing of why maybe we jumped the gun in GI cancer disease, because of this trial called KEYNOTE-177, which remains the only phase 3 trial which has published to the endpoint of overall survival just for MMR-deficient bowel cancers versus, this is advanced disease, so non-operable or incurable MMR-deficient bowel cancers, of which some patients were Lynch syndrome, but that was chemotherapy, which was the standard of care, versus immunotherapy. And this basically was published in many papers, but it was a seminal piece of work, and NICE approved it within months, which I was very proud of. I was one of the lead investigators, and despite the fact that, in a good way though, that the patients on chemo did have an optional crossover. That means even when they progressed on chemo, they could switch onto immunotherapy. Immunotherapy first was better. And this is amazing in bowel cancer, where most people unfortunately die if they've got inoperable disease, within 2.5 years. The median overall survival, that means more than half the patients are still alive, okay, at 5 years when they've had immunotherapy first, okay? So immunotherapy is incredibly powerful. So, of course, this trial was actually set up in 2013, or thought about in 2013, opened in 2016, closed in 2018, okay? So, of course, everyone says, but we can do things better, can't we? And this is the good thing about trials. We never set things up knowing everything. But now everyone's talking, well, okay, single agent immunotherapy, good. I'm not going to go through all the data, but not everyone responded to immunotherapy. So maybe we should give doublet immunotherapy, because that's what we do in melanoma. So the young, fit patients with very bad metastatic melanoma get Nivo Ipi, and it's transformative. In the initial studies, people died in their garage overnight, not knowing why they did. So there are toxicities to doublet immunotherapy, and one thing we have to think about, particularly in bowel cancer, is there's lots of other treatments for you, okay? And I think this is very important. When I see patients, they desperately want immunotherapy, and I agree. But some of the risks are too great, because there are other things we can do for bowel cancer, which we, for example, can't do in melanoma. But anyway, so the first question I would ask is, who only needs pembrolizumab? Who needs more than that? And how can we select things beyond MMR deficiency and MSI testing? So we'll talk about the diagnostics and making diagnosis of Lynch, incredibly important, okay? I'm talking about therapy now with immunotherapy, which is very important. Then there's a whole question about how long you need to give it. Okay, do you need to give it for 2 years? Should you give it for more than 2 years? What do we do about metastatic patients who we could have cured with surgery? Because by definition, NICE has not said if you've got curable metastatic bowel cancer, you cannot have immunotherapy. It doesn't define any differently. So now we have to engage the surgeons, which I'm not sure that any surgeons are here. Maybe next year we should invite some surgeons, because it is basically telling them, don't get the scalpel out immediately. Think about a little bit about whether we should give immunotherapy first, which moves into immunotherapy in the neoadjuvant setting, which is early stage disease, where they haven't relapsed metastatic disease, where the field's going. And I'm sure you've seen on Twitter, it lit up Twitter last year, about the dostarlimab trial for rectal cancer patients in Sloan Kettering, which I will show later. So basically, I also want to show you that it's beyond this. So although I've been asked about checkpoint inhibitors, there's more than that. So I'm sure you've also heard, maybe because of COVID, maybe it's a silver lining of COVID, that cancer vaccines, particularly now even mRNA cancer vaccines, are all the rage, and most of my patients want one. Okay, so that's all they're asking for me, whether they've got Lynch syndrome or not. I want a vaccine, which is good, unless they were anti-vaxxers, I guess. But there's other cellular therapies too. And of course, for me as a clinician scientist and a trialist, of course I want to know what trials are available, but just what Amanda was saying, you don't need necessarily trials, you need studies, okay? So some of the best thing is we get our best ideas from retrospective analysis, and if we could get all our patients who have not yet developed bowel cancer from Lynch syndrome, we can learn from all of them. Now, I just wanted to say this because, again, I understand there will be a number of patients and carers here. Everyone wants to have immunotherapy, it seems, okay? So I just be a little bit careful when we talk about giving immunotherapy for any stage cancer. I'm just using bowel cancer for this moment. So we already know if you have a polyp cancer or stage 1 or 2 bowel cancer and your MSI high, prognostically, actually, you've got a very good survival. So if you chop it out, okay, in stage 2, you've probably got a 90% survival rate at 5 years already, okay? And you probably heard chemotherapy doesn't work. The reason is you don't need it, okay? Probably your immune system, okay, at that point when you chopped it out, has already got, because your immune system is very clever actually, every day it's trying to kill viruses, including little cancer cells. So you've already got an immunogenic cancer in you. You chop it out and your own immune system can probably deal with it. Okay, so that's why I have patients sometimes say, I'm very disappointed that somewhere in America, someone's giving immunotherapy for my stage cancer. And I said, there is no evidence, okay, to do that outside of a clinical trial. In stage 3, okay, much more uncertain. Once you've got lymph node metastases, local regional disease, we're not quite sure. You're starting to lose your immune response or your kind of protective immune response. And certainly in stage 4, although I've just shown you some very transformative data from Keynote 177, not everyone responded. And why is that? Well, it's way better than chemotherapy, but you could say you've already kind of not lost the battle, but it's going to be harder, and some of the patients won't have those durable responses. Having said that, my melanoma and lung colleagues say the survival benefit is way better. Okay, single agent pembrolizumab is way better for survival, durable remissions than melanoma, for example. But just to be aware, the biology changes through stages. So I'm going to go straight to the case because I like cases and, you know, it's just kind of illustrative. So this is one of my own patients presented with originally thought to be IBS syndrome with weight loss, abdominal pain, constipation, but was obviously had a microcytic anemia with a normal CEA, no comorbidities, never smoked, an anti-vaxxer, which is, in a sense, he was too young. He felt, I'm too young, I'm super fit. Why would I need a vaccine? But his father, interestingly, had multiple cancers. In fact, he was referred to me by the father's kind of gastroenterologist, saying something is a bit weird here, okay? But anyway, she did a scope, and it was a very bulky, you can see, impassable bleeding tumor, okay? And when we did a CT scan, it was pretty scary. Okay, I hope you can see, sorry, no pointer here, that the tumor's on the left hand, I can't really, this is the tumor right here, right next to the psoas muscle. You'd think he's about to obstruct. Actually, he was kind of just walking around feeling okay-ish, okay? Then he unfortunately definitely got some liver metastases, but they're small. So we've staged as a very nasty tumor. It's kind of involving the small bowel, it's touching the kidney, it's touching the psoas, so a bulky, locally advanced cancer, and on top of that, some small liver metastases. So at our institution, we do reflex testing for MMR, but we also, for him, because he has MLH1 and PMS2 loss, as what we were just talking earlier, we went straight for MLH1 methylation testing, and also we do KRAS, NRAS, BRAF, POL pending because it's got metastatic disease. Actually, luckily with a genomic hub through the Marsden, any stage bowel cancer, we do the KRAS, NRAS, BRAF, POL, and DPYD. Now, actually, our surgeon was pretty gung-ho. They wanted to operate because they thought he's about to obstruct. We're just going to get this out, okay? On the day of operation, he rocks up with symptomatic COVID. The surgeon rings me up going, this is just as we're coming out of COVID. Says, no, the rule at UCLH is 6 to 7 weeks before we can operate because the anaesthetist, even on a 40-year-old, said he could die. He had, you know, symptom. He didn't have infiltrates on his chest x-ray, but he was very symptomatic and coughing. At that point, we had got the MLH methylation test. It was not methylated. So it was methylated. So that was like, oh, we can talk about this later. But, that's really weird. But okay, so he's not methylated, but he is methylated, but he's still got MMR deficiency. We've got to get on with this, okay? So they said, over to you, Kaikin. So we gave him some Paxlovid without the steroids, because I wanted him not to be, for various reasons, not on steroids before immunotherapy. And I think I treated him 10 days. Okay, I was we treat COVID positive patients all the time at UCH, so we just wanted to get on with it, all right? So we said, look, it's risky, but you're about to obstruct, we've got to get on with it. So he wasn't in a great state, he was anemic now, he had lost a lot of weight, and just after 3 cycles, I hope you can see a dramatic response. So the tumour is this thing here compared to that, and the liver mets have completely disappeared, okay? His CA hasn't really changed very much, but it's normalized, and his hemoglobin without a blood transfusion, by the way, because we weren't operating on him, so we just gave him immunotherapy, has already shot up, okay, so he's not bleeding. After 6 cycles, we repeated the scans, and again, I'll just show you that really the tumor has shrunk even further, so it's this tiny thing here, okay, and the liver mets have disappeared, and we did a PET scan, and the tumor is this tiny thing here, okay? So at least on that, so we thought, well, that's it. Remember, he's now a bit fat, not fat, but I mean, he's gained a lot of weight. And we thought we'd scope him, okay, because the surgeon said, right, let's go and operate. So I just want to show you that was his tumor at the beginning, and now it looks like this. It's very weird, isn't it? In fact, we still couldn't pass it because it was so polypoid, but he was in obstruction, but we biopsied it, there was no cancer. Okay, I'm going to stop there. I don't know whether an interview with a bit. So we have an option here: surgery versus no surgery. Who would want an operation now? We can cure him by an operation. All right, it's all shrunk down. There's no cancer, certainly in the bowel. He's in a very good physical state. Who would want an operation now, and who would want to continue immunotherapy? Show of hands.
Well, you have to go. That's one at a time.
Okay.
Who's for operation?
Okay.
Who's not for operation?
Okay, right.
Who would rather not be in the MDT?
Okay. So the patient really didn't want an operation. He was incredibly happy. He had already read, okay, this time we had got the stone catching data, we've got the keynote data. I showed him what we call the duration of response curve. So if you're already responding, the chance of him non-responding for the next year and a half is almost 0, okay? He's got incredibly good quality of life, and in fact he was a little bit scared because the surgeons wanted a pan-subtotal proctolectomy, and he went, no way am I going to do that. He's still going around wanting segmental surgery, though to be honest, the way he presented with that infiltration of the small bowel, he may need quite a big operation. So he has decided not to have a surgery yet, okay? So he's about a year and a bit now in, he's completely fine, and we're just sitting on him. So he'll complete his 2 years of immunotherapy on the NHS, and then he'll decide what he wants to do. So again, patient-centered approach, yeah? So we will go with the patient. We can't force him to have an operation, and fair enough.
Yeah. Did you biopsy all that?
Yeah, it was done on.
Yeah, so it's normally just granulation tissue, yeah, nothing. Okay, so very quickly, more is more better. So there's 2 big studies. Hopefully, actually, some of it will be presented this year, next year. I've been talking about this for a few years now. So one is just to combine chemotherapy and a drug called bevacizumab with immunotherapy. That's called the COMET trial. And the other trial, which I'm actually more interested in, is the one that is Nivo-IPI versus Nivo versus chemotherapy. Okay, so these 2 studies, COMET and AHW, some of the initial results will be presented later this year, just in terms of response rates. This is metastatic disease response rates and progression-free survival. Overall survival will take a little bit longer, okay? But these are very, very important studies to show. What I would say is that the toxicity profile will definitely be higher, okay? Pembrolizumab, in terms of toxicity, there was a 3% chance of a grade 3 diarrhea, grade 3 hepatitis, but no one died. I already know that some patients have become incredibly sick with these combinations, talking to the lead investigators. So I think this is also very interesting. This is what I call the next generation Keynote 177. I'm going to ignore cohort A because, to be honest, in our country, luckily, NICE have approved not just first-line pembrolizumab. I hope you realize they've also approved second-line Nivo-IPI. So if, unfortunately, your oncologist gave you first-line chemotherapy because they didn't know about the data, okay, you can actually have the second stab and you can have second-line nivo-ipi. So none of us are going to be going into cohort A, but this trial is open, I think, at the Beatson, Leeds, I think, and Coventry, and me. Cohort B is where we want to go. So essentially, bit like patients who have never had any form of treatment, systemic treatment, chemotherapy for metastatic MSI-high bowel cancer. They all get pembrolizumab because that is the new standard of care. And now the company just throwing all their bivalent, so with CTLA-4, like ipilimumab, LAG inhibitor, TIGIT, IL-4. So I think that's very nice because it's very mobile and quick, and it's going to respond. If you're not going to respond, you drop the arms. I think it's just nice to do these studies now. And that is the future. I don't think we need chemotherapy anymore in first-line patients, in the first line for these advanced patients. Just to show you, yeah, so this patient has Lynch syndrome. She had avoided seeing any doctors or surgeons for quite a while, and obviously then kind of like a massive tumor, I hope you can see in the engulfing her sacrum, very symptomatic, okay, obviously not operable anymore. And so we managed to get her compassionate access nivo-ipi from the company because she had Lynch syndrome, and you can clearly see just very quickly, we didn't defunction or anything, we just cracked on with it. You see how the tumor has massively shrunk down and has essentially become very mucinous and fibrotic. So after 3 months, after 9 months, and this is after 24 months where in fact we now stopped the treatment and we're watching her. She's very happy because she's avoided surgery, but it wasn't without side effects. So she had something called hyperphysitis, which your pituitary close basically shuts down because you basically get inflammation of your pituitary gland. Manageable as an outpatient, but had to be on steroids. And then normally once you get one side effect, you get at least a second one, and then she got myalgia and arthralgia, and rheumatologists are get involved. Still, good quality of life, but she'll have to be on lifelong steroids now. Low dose, physiological dose steroid, probably forever, but hey, she's lived, okay? And in fact, we'll talk about it later, she has options, okay? But if she relapses, but at the moment she's very happy. I just want to show you, because we'll come back to this about vaccines. Okay, so rather than thinking about two unanswered questions, so ipilimumab is toxic. So now we think about vaccines. So this company, which I know John is very aware, and it is called NOUS209, have made 209 stands for 209 frame-shift peptides, which they think they've created a vaccine against. They use a whole panel of patients of MSI, of all types of MSI cancer, Lynch and non-Lynch, not just GI cancers, and they basically made a kind of monkey vaccine, that's all I'm going to say. All right, so it's very easy. You prime them on day one and you give them a couple of boosts, and they showed already in another kind of cohort of patients that they had a very good immune response to that. It was safe, it was absolutely fine, just like any kind of vaccine. And now they are doing this study. So cohort C, okay, is again like Keynote 177. No prior treatment for advanced metastatic MSI cancers, just 63 patients. Experimental arm is pembrolizumab 3 weekly with the vaccine versus pembrolizumab 2 to 1. That means pretty generous, 2 to 1 randomization. Fine. So I'm hoping to open that study. It's just a bit tricky with the vaccine, but we're going to open that study soon at UCLH. I'm really also interested in if any of you have already had immunotherapy, what do we do for patients who have had immunotherapy, had an amazing response, and some of them relapse? What are we going to do? Go back to chemo, go back to radiotherapy, go back to surgery? Yes. How about boosting up your immune system again with a vaccine to see whether that will make the pembrolizumab kind of work and get over that resistance mechanism? So that's a non-randomized study. I just want to say, I went to the REC committee to get this study at UCLH, and the statistician and the team said, why don't you just give everyone the experimental treatment, even in cohort C? And I went, I'd love to do that, but the FDA, quite rightly said, you cannot use the old data from Keynote 177, it has to be contemporaneous. So even REC felt that we should not be randomizing these patients and everyone should be getting it, which just shows you that the REC committees are kind of thinking like an oncologist, which is pretty good. So I just want to say it's the beginning. So there's some challenges about what do we do about non-responders. I haven't really talked about that, but not everyone did respond, okay? But in the responders, we have to think very well how we integrate immunotherapy now with our tumor board, MDT, because we do have other treatments, surgery, radiotherapy, stereotactic radiotherapy. And we also have a bit more understanding about why is there heterogeneity within MSI height. There's heterogeneity within any tumor type. There's heterogeneity within MMR-deficient cancers. There's heterogeneity within Lynch syndrome patients. Okay, so just be aware of that. And now there's concern about liver metastases, that there's some macrophages that mash up your T cells, therefore you don't get an immune response. And we are very interested with the gut microbiome. Okay, we've not studied it so much in the bowel cancer patients because it's messed up. Okay, we've ordered cancer. But there's some very interesting work where melanoma patients and lung cancer patients who have not responded to immunotherapy get a fecal transplant from a patient who did respond to immunotherapy, and they respond to immunotherapy. So wow, isn't that amazing? Okay, so although there are challenges, there are loads of opportunities. Okay, so pembrolizumab made a new standard of care, but all these different combinations, it may not necessarily be expensive drugs, it could be a bit of poo, okay? Could be the springboard for new trial arms. And I'm going to quickly talk about neoadjuvant procedures, because in general, neoadjuvant, that means giving treatment before an operation. You learn a lot more quickly about things. So in breast cancer, the reason why, in many ways, breast cancer has led the field, apart from the advocacy, which is fantastic, is that in the main, a lot of treatment has been now in the preoperative setting. So you've got operable breast cancer, but don't do the mastectomy, give them a drug, hormone drug, chemotherapy, radiotherapy, targeted treatment, and shrink the cancer down before the operation. I just want to show you, I was going to show n equals 1. So you saw that 0% of patients in that MANTIS study had MSI cancer. Of course, someone who's got Lynch syndrome, okay, would have an MSI high pancreatic cancer if they develop pancreatic cancer. This is a real patient of mine, which just is really interesting. So I didn't see him at the beginning, and so please don't criticize that I didn't make the diagnosis at the beginning. He had 2 bowel cancers when he was in his 20s or 30s in another hospital. He had an early stage prostate cancer, he had a thymic cancer, and then he came to me because he had a gastric cancer, all right? And then at that time, the gastric cancer was actually biopsied, and it was said MMR-deficient. Okay, so it's fine, by standard of care, this is operable disease, but it said this is your 5th cancer, something cannot be right here. And I sent him to geneticist, Andrew Kulkarni. He walked into the room, you've got Lynch syndrome. And she was right, he did have Lynch syndrome. The MMR deficiency on IHC was not perfect. There was some speckling or something like that. So this is the read.
Not normal.
Exactly. Yeah. So these are the cases where you think MMR testing is not enough. You've got to do MSI and all the other things. Anyway, very good. Okay, so I did ask the patient, by the way, I said, were you not offered? I mean, he was in the region of North London. And he said, Dr. Shiu, I've got to admit, in that age, when I was 28, or I think 30, I didn't want testing. He said, I didn't want to know, and I declined it. Okay, all right. Anyway, the problem was that then he had standard of care, but whilst he was going through, and he actually went through preoperative chemotherapy for his gastric cancer, he got to surgery, but at that time he found out he was MMR deficient, and he also found out he had Lynch syndrome. So he kind of went, oh, right, okay, so he started reading up about things and says, is there anything that I can do for me to stop me getting another cancer? Before I could think about anything for him, he got what we thought was a recurrence of his stomach cancer. In fact, no, he had a tail of pancreas cancer, which was really weird, okay, after 3 years having had gastric cancer. So the problem was it was stage 2 pancreas cancer, so standard of care on the NHS, you cannot give neoadjuvant immunotherapy. So he had standard of care, horrible chemotherapy again. So he's had chemotherapy for gastric cancer. He's now triplet chemo for gastric cancer, triplet chemo for pancreas cancer. He did respond. So he had to have an operation. He had an operation. It wasn't great. There was disease left behind. We knew he was going to relapse. Again, no trial to get him onto adjuvant immunotherapy. So I had to give him standard of care, and then unfortunately he relapsed. Now it all opens up. And again, he was actually insured, but the insurance company said, no way, not approved, off-label, everything. So you go back to the company, you plead your case, and he got it. So he got nivo-ipi, and you can see this tumor, which is this recurrence, which is wrapping around his kidney, okay, with a very elevated tumor marker And after just 3 months, it's pretty much disappeared, okay? And he's now on maintenance Nivo, and he's now about 18 months in, and he's had a bit of a up and down with CA19-9, but his tumour is actually under control. And what we've actually done with him is, just to keep it really under control, we've given him stereotactic radiotherapy just to maximise the response, because this is never going to get resected. So just a very interesting case. So just to say, it does work even in pancreas cancer, but obviously he's MMR deficient. So there's a very noisy slide, but I think all I'm going to say is that we don't really understand how immunotherapy works. There's many ways that you go from the cancer antigens being released to kind of the actual cancer dying. We've got the microenvironment, we've now got the microbiome, and the slightly scary thing is this de novo resistance. So we do believe this exists. That means patients just actually won't respond to these drugs. So we have to think a little bit harder. Maybe there's a thing we have to go beyond that. So I'm sure you've heard about CAR T-cell therapy, lymphodepletion and all those things. Well, actually, the companies are very interested in patients with Lynch syndrome because inherently think you will be the people who will get their drug over the line, okay? So they're looking for you, but not in the way that I'm looking for you. But I mean, if you ever got to that stage, they're looking for you, and I'm kind of looking for you too, all right? Right, very quickly, okay? So I'm sure you heard about, well, you may not have heard of niche because it kind of came under the radar. The Dutch just very cool about this, all right? So Sloan Kettering hit up Twitter. Niche had already published this data a few years earlier, just giving short course Nivo-Ipi, just 2 cycles of nivolumab, 1 cycle of low-dose Ipi, operate within days of the immunotherapy, and you had a 60% pathological complete response. That means when we cut it out, no cancer in the specimen, disappeared completely, all right? And then all of them pretty much had a major pathological response. And what's very interesting, just to let you know, is that they actually tested it on some MMR-deficient cancer patients, and they added in some celecoxib, which is like aspirin essentially, and they had some responses there. So it just shows you that the neoadjuvant setting can teach you a lot of things, okay? First of all, wow, this exquisitely sensitive immunotherapy, but maybe we can get immunotherapy into our non-Lynch and non-MMR-deficient cancer patients. Very important, they all got the curative surgery, they all had anastomoses, but they did a few leaks, probably from colitis, but no deaths. Just to quickly show, during COVID, this is a PIC trial by my colleague. Just to say, these 3 studies, before I talk about my study, all led by women. So someone was talking about women, I absolutely think it's amazing. Okay, so all the women, even at Sloan Kettering, it's incredibly kind of male-dominated kind of department in the past, all the leading lights in most of the tumor groups are women, which is fantastic. Anyway, this came under the radar because unfortunately probably it was in China and it was like, But basically they've got their own homegrown PD-1 called Tori, I got it as Tori, and they also gave celecoxib, which I think is really interesting. So it's really interesting, just 3 months of single agent PD-1 plus or minus celecoxib, and just the PD-1 alone, okay, 65% pathological response. Again, so 2 drugs, fine, but maybe 1 drug, also fine, if you give a bit longer. And really interestingly, if you just gave celecoxib, and why don't we just give high-dose aspirin, the pathological response is 88%. Now, again, all these are small studies, but just really interesting, cheap combination. So, Miriam Chalabi, who's a woman, expanded this study out to 100 patients and basically went from 1 site to 6 sites in the Netherlands. And she also wanted to prove that it wasn't just a spark in the pan, and she was really going for the locally advanced cancers. Remember I talked about that actually in the niche one, what was shown was about 25% of the patients had stage 1 or 2 bowel cancer. So you could argue they would have been cured by surgery alone. So she went for it this time. She went for really nasty tumors. So high risk stage 3, that means these were T4AB, like the patient I had without the liver metastases, and lots of lymph nodes, okay? And this is just to show you how nasty they are. Can you see how nasty these tumors are? They're going up the abdominal wall, going to get kidney, going into the bladder, so these are really nasty tumors. And despite that, this is what they showed. And so this is now, I don't know, this is oncological speak. So we normally talk about waterfall plots, okay, which means, this is called the chip off the block, or a lake, all right? Because basically, everyone's responding. Totally amazing, okay? So major pathological responses in 95%, with a path complete response of 67%. Very interestingly, some of these patients were offered adjuvant chemotherapy, okay, but almost none of them wanted it, okay. So although some of them did have some residual disease, most of them refused, and none of them have relapsed so far. None of them have relapsed so far. Just to show you, a very, very interesting thing was a lot of people have been asking, and I'm sure you will ask, will I respond better as a Lynch patient? I've heard some scary stories, maybe yes, maybe no. Well, in this early stage setting trial, although it's not quite there, p-value of 0.056, okay, it looked very much like the patients with Lynch syndrome did achieve more likely a pathological complete response than the patients who didn't have Lynch syndrome, okay? We can debate that later why. So let's just talk about the one that lit up Twitter, and the surgeons all stood up because in rectal cancer, as you may know, pretty morbid operation. You might need chemotherapy, you might need radiotherapy before an operation, and surgery itself has morbidity to it. So this is a very interesting study. So it's 6 months of another PD-1 inhibitor called dostarlimab, okay, and just 6 months with the aim not to avoid essentially surgery. So avoid chemotherapy, avoid radiotherapy, and even avoid surgery for locally advanced stage 2 or stage 3 rectal cancer. So it's kind of complicated, but the thing that lit up was that even though it's a phase 2 study, the first 14 patients, none of them, okay, well, needed surgery. All of them responded and had what we call complete clinical response. That means radiologically, when they fit the finger at the bottom, when they did a flexi-sig, the cancer had disappeared. It was so good that the next few days, my breast cancer colleagues said women were going to their breast clinics going, I've heard about this drug, dostarlimab in the New York Times, I want it, okay? Says, you don't even have the right cancer. But I mean, the fact is that the newspapers don't really forgot about mentioning the type of cancer that these patients had got, okay? Now, very important, lots of debate around, you know, are rectal cancer patients with MMR deficiency slightly different? That is a phenomenal result, okay? The first 14 patients, if that was a randomized trial, someone would have stopped the study and said, forget the control arm, yeah? Just give everyone immunotherapy. But just be very careful. First of all, the predominants were female, okay? Predominantly Lynch, okay? Yeah. And the lead, again, a woman, Anja Sursek, amazing. Basically, kind of made the big play that it's because they wanted to avoid, of course, the side effects, you know, infertility, bladder dysfunction, dyspnea, all those kind of things. So she made a big play around the fact that, of course, it avoid those kind of toxicities. So you've just got to remember that the patients who go to Sloan Kettering are really quite minded of what they want to do, okay? So they're all very happy not to have surgery. The surgeons are very happy in one way. I can tell you some surgeons were really not happy. They said, that's not right. These people are in their 20s, okay? They're going to have prophylactic oophorectomies in the future, maybe hysterectomies. What are you doing to them by not operating on them? Now it's short follow-up, but I just want to show you how dramatic that response is. I've already shown you one picture, but this person, for example, did have a scope. I don't know why at 6 weeks. It wasn't in the protocol. But you can see already within 6 weeks, the tumor is shrinking beautifully, and basically everything is melting away. So the thing I would just say this, if you do, unfortunately, ever need to have immunotherapy and the surgeon wants to jump on top of you and operate, ask them to scope you first, because the CT or MRI even doesn't necessarily show you what's going on. You need to directly visualize the tumor and do a biopsy. So even they were saying, it's not yet practitioners. Everyone said, of course, we should just all do it, shouldn't we? Because it was a small group of patients, a very select group of patients, and we know that eventually 1 or 2 will relapse, okay? And this is the concern, and we can talk about it later. If you relapse, maybe you relapse badly, okay? Because you've lost your immune protection, okay? So that's not good. And what are you going to do about it? Of course, you can say resect it, but then you're back to the kind of the bad. So maybe you should just resect it now. Anyway, the main thing is it gives people choices, and we can debate about, you know, how much choice we have outside of a clinical trial. I just want to show you a patient who had a locally advanced cancer. Again, a real patient of mine. I managed to kind of bodge this one, which was he had a really nasty tumor. So he was about to obstruct. It was going into his seminal vesicles, into his prostate gland. And I kind of said it's metastatic. Okay, so I said, look, this guy needs to be defunctioned and I need to get him on immunotherapy. So he was defunctioned, and you can see that he, again, he didn't have a strong family history of cancer, but he was probably only 39 with a young son. So MLH on PN stars, MLH not methylated, so likely to be Lynch syndrome, and it was proven to be Lynch syndrome. MSI high with a KRAS mutation. You can see a very nasty, very active tumour on a PET, and there's this nasty tumour in his rectosigmoid. He had a colostomy, and we just started immunotherapy within about 12 days. Okay, so we started 14 days post-op, and you can see just after 3 cycles with no side effects, no colitis, you can see the tumour's essentially switched off, right, and it's melted away. So there's minimal residual tumour, reduced mucin. So again, he wasn't minded for surgery. Remember, if he had surgery, it would be like a pelvic exent. He'd have to remove his prostate gland, probably lose his fertility, all those things. So he's very happy to continue. So after 6 months, we scoped him, and you can hopefully see there's nothing there. Okay, it probably wasn't there 3 months ago as well, but we scoped him, biopsy proven complete response. So he's continuing on 3 weekly. He's now on 6 weekly pembro. Pretty good side effect profile, bit of a grade 1 rash, bit of a nasal polyp, but all manageable. He was just emailing me saying, do I need to be on this prednisolone for his polyp? Anyway, the plan is the surgeons are actually quite happy that they will just reverse him without a cancer resection, which is quite interesting. So they hope that after 2 years, because we've proven that it's melted away, he doesn't need a pelvic exenteration. They're just going to reverse his stoma. This is now non-anatomical surgery. Okay, very good. Oh, very interesting thing. He still has lots of polyps appearing, which I'm really curious about. So I'd like some advice maybe from the gastroenterologist, because I thought maybe immunotherapy would have stopped even those appearing, but he's still getting these sessile serrated polyps appearing every 6 months or so.
Whereabouts?
I can't remember. I'll have to look at the picture. Okay. Yeah, I mean the gastroenterologist hopes that over time it doesn't seem to be as many, and he'll just clear it out. This guy doesn't want to have a pattern proctolectomy, by the way. He also wants some kind of segmental, he doesn't want any surgery, he just wants to be reversed. Very quickly, I know I'm totally running out of time now. We've talked about MLH testing, we've talked about MSI testing. Well, okay, next generation sequencing is here already with some commercial tests, and maybe something called tumor mutation burden may help us decide whether some patients will respond better than others, and we can go through all the gene lists, but I mean, basically, all I can say is this patient has an ARID1A mutation, which we know probably is a pan-tumor marker for response to immunotherapy. We also know that we can do liquid biopsy. So we're talking about urine, great, blood in general, but there are commercial tests. And this is a patient who had a locally advanced bowel cancer who we couldn't scope again for more tissue. So we actually did a liquid biopsy and showed, because we had not enough tissue for the quality for the MMR, and my God, she's MSI high. So she got nivolumab during COVID. Complete response. So very quickly, I've shown this slide before and we can talk about it later. This is my own study, which is open now. We opened in June of last year. It took 3 years to get going because of COVID and all the delays. This is just a really straightforward study. 3 weeks of pembrolizumab, 1 or 3 cycles, depending on the TMB. You have actually a baseline CT scan and a trial colonoscopy where we take normal tissue and extra tissue for lots of different translational things, including liquid biopsies, pre-cycle 1, pre-cycle 2, pre-cycle 3, pre-op and post-op, to see the dynamics of the response. This is a learning curve for us, okay? So very small study, run at the moment. The 4 sites open are me, Southampton, Christie, Leeds, and Beatson are coming through. We've already recruited 50, this is slightly sensitive, but basically 15 patients have already been recruited out of 32 within 9 months, okay? So we originally were going to close this trial next year. We're probably going to close it this year. However, I'm going to the company to ask them to expand the study, a bit like Niche 2, because at the moment there are not that many studies coming through in the UK, and this is a very important study. Okay, I'm going to also show you something very confidential, so please don't take any pictures. This is an actual patient, okay, who's young, she's in her 40s, a hepatic fracture tumor. Hopefully you can see nasty, right, bleeding, anemic. She had a hemoglobin of 6. We did give an iron infusion and some blood to get on the trial. Very nasty tumor. It's basically underside of the liver, touching the duodenum. Actually, I probably showed it to someone at the Christie and said, your surgeons are mad. I mean, we wouldn't have even thought about that this is ever operable. I think you should have just treat her with 2 years of immunotherapy. But we were pretty sure that she had no metastases and very keen on this trial. So that was a scan. We did, so she got 1 cycle within, you know, she didn't drop her hemoglobin, her pain, she was in a lot of pain, back pain, everything, that went away after 2 weeks. MSI high, mutation burden very high, 40, okay? She's all wild type. She's got a BRCA mutation, which is we're not sure is real, but she's probably got Lynch syndrome. We're just trying to confirm this. It's a bit of a struggle because of her cultural background. She's not sure. Again, she wants to definitely know. She says, I don't care. I've responded. I'm not sure I want to know that anyone else know what's going on. But anyway, look at this. So just after 3 cycles, hopefully you can see that tumour has really shrunk away. It's gone to this. Okay, so it's a CT scan just 2 weeks after cycle 3. And now I'm going to show you something very interesting. This is the resection sample. There is no tumour left in the bowel wall, okay, just a scar. We looked at it. In fact, there was one lymph node, which was a bit annoying for me, but there's one lymph node. We actually tried to grow an organoid from it. It means that you actually try and grow a little thing, didn't grow. So our organoid specialist said, well, it's probably because it was actually dying anyway, like a dying lymph node. And we did operate after just 4 weeks. So one of the questions is maybe we should have operated after 6 weeks. Yeah. But anyway, it doesn't matter because the patient said, I'm really happy. I said, I could give you some chemotherapy. You've got node positive disease. But she says, I'm really happy. This is a 4-day laparoscopy right hemi, and she's getting on with her life. Okay, so I'm seeing her next Tuesday, about 6 months after that operation, and she's just going to be watched very carefully. Just to show you that it's not just in colorectal cancer, this is a really nice study by my colleague Thierry André in the Sorbonne in Paris. So he did neonapiga, which is neoadjuvant nivo-ipi, so the combination in operable esophageal gastric cancer, really nasty type of cancer, okay, which are MMR-deficient. And basically, I'm going to show you that the response, it was a small study, just about 33 patients, and there was a pretty close to 59-60% complete response rate to immunotherapy. Some of them did not have surgery. Interestingly, one was metastatic, okay, therefore wasn't eligible, but none of them have relapsed. Okay, so this is a short follow-up. So this is how powerful immunotherapy can be. Maybe it can replace surgery, and particularly gastroesophagectomies, Ivor Lewis operations are not simple procedures. So the surgeons are definitely sitting up going, great, okay, maybe more of you should get immunotherapy. Just want to quickly show you, because we're going pan-tumor, this is my colleague, Mike Overman at MD Anderson. He just went for a Pembro, 6 months followed by surgical resection or to continue a year, included mainly colorectal, but also had endometrial, gastric, meningioma, a duodenal cancer, and pulmonary cancer, and a pancreatic cancer. Just to quickly show you that, half the patients went for surgery with a very good pathological complete response. Median cycles before the operation was just 3. So some patients jumped, like I think a lot of you wanted to jump, and that's fine, okay? But some of them just decided, no, I don't want to have an operation, okay? And so they also showed that if you scope them, a lot of them had a complete response. And the time to response was pretty quick. And right now, it's short follow-up, but 17 patients have relapsed, okay? They haven't died, they've relapsed, and now they're having surgery or more immunotherapy. So this is my last 2, and this really beautifully goes to what Amanda says, because I think we really need to kind of talk to each other. So basically, we already know through Kevin Monahan and Lara have done great work, and we've already got, of course, rapid testing for MMR to make sure patients are being tested. But one of my thoughts was this, okay, because we've just talked about all these different treatments for patients, all right? What I have been asked now by Kevin is to chair a national, immunotherapy bowel cancer MDT, which means that there are a lot of patients on immunotherapy where the surgeons or the gastroenterologist or the patient isn't sure whether they should jump to surgery. So that's one thing. I said, when I've got a bit of time, I'll think about how to set up a national MDT to make sure patients are definitely benefiting from the evidence base of not necessarily jumping to surgery or having continuing therapy. But hey, what about at diagnosis? What about the patients who are carriers? We have now some very interesting studies, and I'll show you a vaccine study which has hopefully come to the UK soon. But what we thought was, right, this is where you don't even know what's going on in your own hospital, okay? So I know we are a tertiary gynecological centre, okay, and they're doing all that prophylactic sparing surgery for BRCA mutations, but they're doing that for Lynch patients as well. I just didn't know it. So they have these massive clinics of all these patients who are being discussed about should they have prophylactic surgery, and they're carriers for Lynch. And I went, oh, okay. And there's trials now to dostarlimab, ovarian cancer, and all those things. So we thought, okay, not only should we get our CNSs to, of course, learn like Lara to do the testing and make sure they get their Lynch testing very quickly, but we want to set up a biobank almost. But the difference to Amanda is I have a translational bank already, okay? And this is actually for patients who want to have treatment, actual treatments or drugs and things like that. So what we're thinking about is that I've just found out from my gastroenterologist, she has 250 people on her books, okay, who she's just scoping for polyps who've got Lynch syndrome. No cancer yet, okay, but of course, right, they will develop cancer. I said, we should just work together. So we're setting up, hopefully, not just a team to sort of make sure everything is done, but we're going to hopefully do a kind of a 2-weekly or monthly clinic where we all sit together and talk about some of these patients and can we access them into therapeutic studies, okay? And this is hopefully my last slide, which I think is potentially one of the future options, particularly for patients with Lynch syndrome, is we talked about the vaccine already, the off-the-shelf vaccine, but there's a concept here that really is very important. Okay, that you can create a cancer vaccine out of any cancer, all right? CAR T cell is not the answer, everyone. You have to be very fit for this. And I am about to do an adjuvant mRNA Pfizer vaccine for MSS colorectal cancer, where they all get surgery, they get chemotherapy, plus or minus a personalized vaccine. But it's not actually for MSI high cancers, for various reasons, which we can talk about later. But I'm just saying, okay, for that vaccines may well be kind of the future for a lot of our patients. And this is the small study which suddenly has, because of all the stuff at AACR, is vaccines are the way to go. So that same vaccine which I talked about in IS 209, before even that trial was opened, they did a small study at Sloan Kettering of patients who are carriers, okay, and they're giving the vaccine, okay, and they're trying to evaluate the immune response, okay, and yes, there's some secondary measures that will they get polyp cancers, will they get other cancers, but 100% of the patients are getting immune responses to a off-the-shelf vaccine, okay. It's very exciting for them. So they're now seeing whether with more investment they can now expand it out, maybe to the UK. So this is a preventative vaccine, not even personalized, but in Lynch syndrome patients, it seems to be incredibly effective. Isn't that exciting? So that's what I suddenly thought, wow, those 250 people sitting in a clinic, I should approach them, I should biobank all of them, and if this study comes to the UK, I've got 250 patients. Not all of them obviously will agree to do it, but then the company went, wow, so we could just do this incredibly quickly. And this is not expensive. This is a one-off vaccine, 1, 2, 3 vaccines, that's it. Okay, so hopefully I've shown you in 53 minutes. I'm sorry, is that 53 minutes? Effective treatment. I hope I talk quickly, but obviously not quickly enough. So effective treatments in most, but not all patients. I think we should reflex test everyone. We can definitely talk about it. I think we should talk about next-generation sequencing, particularly for clinical trials, but it's not for making the diagnosis, it's for treatment. Don't be reliant on CT, as I've said. You've got to talk to your surgeons and work together as a team. We've got opportunities to optimize the sequencing combinations. It's a heterogeneous disease, okay? We've got monotherapy already over the line. Let's think about the combinations in early and late stage cancers, okay? Not just colorectal cancer, not just in Lynch syndrome. And my general feeling is, as an oncologist, is neoadjuvant trials in general will accelerate our understanding of cancer biology. That's very important. And hopefully I'll show you that maybe neoantigen vaccines, whether they're off the shelf or personalized, is the future. Thank you very much.
Thanks, David.